Hi, again, welcome. My name is Dr. Abel, and this is a presentation for Module 1, where we're going to start to learn the terminology used in the newborn intensive care unit. If you were to move to another country, you'd want to get grounded in the language, and to work in a NICU, or even to be able to do well in this course, you need to be grounded in some of the key terminology that's used. So I just want to introduce the people that will be participating. These are all students that have been in other courses, and they're my team that has been working with me to help me. On top is Nicholas Gonzalez. He's our math genius. Next is Kira. Kira actually did a video on what it's like to have a baby premature. She has a baby that is was born very, very premature, and she might be adding some extra special insights. She also has been taking the pediatric courses as well. And next we have Xavier, who is another one of our students. And last but not least is Janine. She's kind of our technical guru in many ways. And so I really personally appreciate all of these people giving up of their time and energy and effort so that you can learn in a more interactive style than just me going over a PowerPoint or even posting a PowerPoint. So let's get started, and hopefully we're going to have fun while we learn these key terminology.
Okay, so basically the way that this is going to go is almost like a form of charades, quiz style. We're all going to take turns asking one of the questions that you guys are going to see on our presentation, and one of us is going to have to guess what that NICU terminology is. We cannot say any of the words that are actually in the NICU terminology, so we have to describe it either by the characteristics, by the treatment, or just the diagnosis itself. All right, you guys ready?
I'm ready. I would encourage you guys to pause before we answer, just so you have some time to think for yourselves before we give what we think is the answer. We actually don't know the answers. We haven't shared them with the rest of us, so it's a game for us too.
Yeah, it is. So Xavier, you're going to be the first one to ask our first question. Ready?
All right, guys. So the first common neonatal disease condition that we have here is a disease that affects the human function and the structure of a particular organ that supplies oxygenated blood from the body to the lungs. This can also be diagnosed during pregnancy, at birth, and later on in life.
Okay.
Well, the picture is very nice clue there.
I'm gonna go with I don't want to say it yet. What are you guys thinking?
I'm just gonna say it. I think it's the congenital heart disease, but I wasn't really sure that really happened in infants and newborns. I usually thought that was for older people.
I mean, supplying oxygen is what gives it.
Do you notice the blue lips? That's very important for congenital heart disease.
Right here. Wow, yeah. Okay.
I did not.
Yeah.
Are we right, Xavier? Congenital heart disease?
Yeah, you guys are right.
Nice.
Okay. All right. Nice one to start us off.
Okay. That was easy.
All right. Let's see if you guys can get this one. So this condition can occur in premature or low birth weight infants under mechanical ventilation when the baby's respiratory system is not fully formed. It refers to damage caused by the mechanical ventilation and long-term delivery of oxygen, which can cause inflammation, scarring, or necrotizing bronchiolitis. And some of the symptoms for this condition are fast breathing, glaring nostrils, sucking in of the chest, and grunting. What do you guys think it is?
Just based off that, yeah, it's okay. It has to be something lung related.
Pretty clearly, yeah.
That picture also is a baby that's intubated, right?
Right. Yeah, that's a ventilator there. So you're on the right track.
By process of elimination, I will take out B and C. but I'm debating between the chronic and the bronchopulmonary.
I think it's chronic lung
You think
disease.
it's chronic lung disease? Anybody else have a different answer? Or are we all
Could be both.
2 answers? I don't know. That's a curveball.
I mean, they're both, because how are we supposed to choose between bronchopulmonary and chronic lung disease?
Right. Well, you know, actually, I don't know if you knew this, but bronchopulmonary dysplasia is a type of chronic lung disease. So you're actually right. It's both of them. It could be both of them. So props to you guys. You figured me out. I tried.
Yes, I knew it. Okay. Okay. That is so sad to see that poor baby.
Yeah.
Oh my God.
Let's move along.
Okay. We're doing good though.
You're
Yeah.
doing very good. I'm super proud of you.
Okay, this one, it's characterized by excess blood glucose that is transferred to the baby during pregnancy. And a lot of times it's characterized by something called macrosomia, which is the baby, the born very large compared to normal size. And then the treatment, you definitely have to monitor blood glucose levels to prevent hypoglycemia.
That's easy. That's B.
Come on. Okay.
Come on.
It's so
That last word.
B.
Yeah, the last word, give it away.
So I just want to look at the picture though, because they seem like pretty normal babies there. I don't see a.
Oh
You
no,
know-
they're huge.
That baby is huge. That's
Okay.
Dr. Abel,
I
that's
see
a
that now.
macrosomic baby, right?
Okay.
The one on the left is the normal size. So now what do you think about the one on the right?
Okay. Well, when you put it that way, it seems a lot bigger.
Wow.
In that case, I
Can
don't
you
know. What do you
imagine
guys think?
giving birth to a baby that size?
I can't
Oh
imagine
my
giving
God,
birth, period. But
I didn't even think about that.
Yeah.
That's scary.
you're wrong.
That's very scary. Okay, well, you guys got it right. Infant of a diabetic mother. So that's written out, abbreviated IDM.
Okay.
All right, next.
All right, guys. So this one right here is usually characterized by a mother who is an addict and results in the baby going through withdrawal.
Yeah, that's I mean, just by process of elimination, it's definitely not encephalopathy because that's the hypoxic ischemic encephalopathy is normally with the head. Congenital diaphragmatic hernia, we don't see anything in the diaphragm area, so that can't be it, right?
No, it's not that.
Intraventricular hemorrhage, I would have to say because the baby's suffering from withdrawal, it'd be abstinence syndrome, neonatal abstinence syndrome.
Yeah, that one.
Is that why the baby's crying so much? Because the baby's suffering from withdrawal?
It will be suffering to withdraw, yes, but it's mostly from the mom being taking substances that they're actually going through the placenta to the baby.
Wow.
That's correct, Xavier. And then when the baby
right.
is born, they actually are going through just what an adult would do when they are trying to come off of a drug. So they are literally might have the shakes and the shimmerings, and they cry all the time. And we actually have volunteers who are usually older people that come in and do nothing but rock these babies almost 24/7 because of what they actually go through to withdraw from the crack or the cocaine or whatever drug of choice that the mother took in.
Oh my God, that is so terrible.
That's rough.
So abstinence
rough.
basically means that they're
It's not there anymore.
Yeah, and I just want to reiterate something that Kira said, that it is terrible, but again, these moms, addictions, they don't have control over the addiction as we do as adults. And granted, they could go and get help, but sometimes their lives and their scenarios are really, really challenging. And to really support these mothers through this time is important as well. And so, and that can be very challenging because it is a self-induced situation to the baby. So those can have some personal issues within ourselves.
Wow. Okay. All right, moving
I
on.
know.
Oh,
All right. So
this is the one I like to leave.
this condition is common in premature infants because their bowel is not matured yet. In this case, the wall of the intestine is invaded by bacteria, which causes local infection and inflammation that can ultimately destroy the wall of the bowel. Certain symptoms include bloating and a discoloration of the abdomen, like you can see in the picture, as well as bloody stool and diarrhea, poor feeding, like they don't really want to eat, or vomiting after feeding. So what do we have here?
Okay, definitely not the liver, not penile,
Definitely not the liver.
and not NAS, because we just went over that one.
We did. So do you think it's hernia?
No,
Why not?
because I know how that looks. I've seen tummies
Yeah.
like that in the NICU.
You can't argue with that logic.
What does that look like, Kira?
It's there. You can clearly see that there's something wrong going in the gut. So
Yeah.
I know what it is.
Yeah.
So tell us then, what do you think?
And the day before, they might have looked normal. Yeah.
Mhm.
Many of our premature babies actually die because of this particular disease. It's very sad. I one time had twins that were growing and thriving and doing well, and within 30 minutes, both of the twins developed this particular thing, and both of them passed away. I remember I personally wept for a long time because it was so hard to watch and understand.
Oh my goodness.
Oh.
Well, just because it is gut related, and if we have an entero is gut, so necrotizing enterocolitis. Neck.
Perfect.
That's
Perfect,
what neck,
perfect.
I can't
Neck.
believe that's what neck actually looks like. I know, like
Yeah.
we learned it, if you've taken like Dr. Abel's other pediatric courses, like we hear about it.
Mhm. And it's heart wrenching because they're put on NPO, and if they already were receiving their nutrition, they already know what hunger is, and
Oh my God. So they literally
right.
feel like they're starving.
Many of them will have to go back to parental nutrition, not all of them, but it's very challenging for the family and healthcare providers.
Oh my goodness. This is a serious one for sure.
Yeah.
I feel like all of these are serious.
They are.
All right, my turn. Okay, this one was hard to describe. So a heart defect that's caused by problem in the heart development, where there's an opening between two blood vessels leading from the heart.
Okay.
Keyword
So
is opening.
yeah. I think vessels too is a nice keyword. So we know it's not necrotizing enterocolitis.
Yeah.
We
That's
just saw that one.
related.
I see a picture of the heart, and therefore I wouldn't say the liver or enteronutrition associated liver disease. So it's between the distress syndrome and patent ductus arteriosus.
it is arteriosus.
It is. Yeah, you're right. You're right.
Yeah,
It wouldn't
Yeah.
be respiratory distress syndrome because that would be with the lungs.
the lungs.
Right.
Right.
So
And
a little heart.
If I'm not correct, every baby is born with this, and then it closes. But
That's correct, Kira. That's correct.
in preterm babies, it doesn't close.
So it's ones that don't close that we have to keep an eye on.
Mm-hmm.
Oh, okay.
Wow.
Okay.
So normal babies, it normally closes on its own after birth.
Mm-hmm.
But premature babies, it's not able to close.
Sometimes it does,
Sometimes it does.
but sometimes it doesn't.
Is there is there a treatment for that, or do we just have to like monitor and wait for that for it to close? What
They
happens?
wait, but they also monitor, I think, the oxygen levels. So
That's correct.
there's a small surgery that can be done, or also giving I think ibuprofen.
Wow.
That could also
Good
make,
job, Kira.
yeah. My baby had that, but it
For
does.
Michaela.
Yes.
Okay, nice job, guys. Next.
On this one is characterized by abnormal development of the eye, blood vessels in premature infants.
This one is like super hard not to give away.
Yeah.
Make these easy, that's for sure.
Yeah, definitely ROP, retinopathy of prematurity.
Yeah.
And then, so what happens in this case, Dr. Abel?
Well, there are definitely different levels, and it can go on a continuum all the way to what we call blind. You know, the baby can become blind. So it is all different levels for sure. And again, I just want to reiterate that like the brain and the eyes are what's developed in that last trimester. So this baby was born before all of these organs are completely mature and developed and ready to go. And that is our goal, to help nourish them to the place where they can, on the outside of the womb, continue to have the organs develop. The reason that we actually did this presentation is you will have an assignment where you're going to pick two of the different disease states, and you're going to actually do a little research on your own, where you're actually going to investigate and look at a little more information on the disease state. That's why we didn't completely teach about every disease state. We just want to kind of get you interested in different types that do go on in the NICU. And then you're actually in the second paragraph, you're going to write out how this, what kind of nutrition plan would you be providing for a baby with one of these disease states. And of course, you're not completely an expert in this area, but as you start to explore the literature, you can actually start to develop what actually happens from a nutrition point of view in all of these different types of diagnosis that we find very common, unfortunately, in the premature population.
Okay.
Yeah, there's a few more important topics. First one, well, yeah, we could talk about birth weight. We did do a calculating video to show how to determine the corrected age depending on when the infant was born. But, you know, I have a question for you guys. Why do you think we need to have different categories for birth weight? Why is it important to differentiate between them?
Yeah, you know, I know that when you read through a lot of the advanced pediatric nutrition research articles, I always saw, you know, before it's like there's, if I'm wrong, there's like extremely low birth weight, there's low birth weight, there's very low birth weight. And at first it was really confusing. Like, I didn't realize the categories, but I believe it's because depending on their actual weight will be dependent on the amount of energy, like the energy recommendations or needs and protein needs.
Right. Yeah, that's true. It's also important to consider that, as Dr. Abel was mentioning, with the eye and the brain in the last trimester, some organs are not as developed in lower weight infants because they were born earlier, so they didn't have the chance to develop in the womb. And because of that, the different treatment plans tend to differ based on size and age of the newborn. So Janine, you just told me about some of the different types, like low birth weight, very low birth weight. Do we know what classifies them as low birth weight, very low birth weight, or extremely low birth weight? right? The grams.
Okay, I always get confused. Let's see. I think so. First, it goes low birth weight, and
Right.
that is
Do you want to say in grams what size your baby was at birth?
She was 1,090 grams.
Just a little over 1,000 grammer.
so 1,090. Would that be very low?
Yes, it would. Yeah, it would. So let's start with low birth weight. So low birth weight infants are under 2,500 grams, and I don't know grams, so that's about 5.5 pounds. So low birth weight is under 2,500 grams, which is 5.5 pounds, and then very low birth weight, which is like your baby was, it was under 1,500 grams, which translates to 3.3 pounds. Then the most extreme case would be the extremely low birth weight is under 1,000 grams, which is 2.2 pounds. So very important to differentiate
And
between
the
these.
smallest baby that I experienced in the NICU was 570 grams.
Wow. Well, actually, the picture here is also an extremely low birth weight infant. So that's under 1,000 grams.
Yes.
Which is very tiny.
Yeah.
Very, very tiny.
Tiny, very tiny. Wow, that's crazy. Okay, well, I'll definitely remember that. So low birth weight, less than 2,500, very low birth weight, less than 1,500, and extremely low is less than 1,000. Okay. All right. So now these are a lot of other like common abbreviations that you'll see a lot of times in medical records. So these are important to know so that you're not confused when you're, writing charts or having to look through other electronic medical records. So this one is a measurement of how quickly a patient needs to receive, keyword here, carbohydrates.
That's going to be D.
The GIR, yeah, glucose infusion rate. So the glucose infusion rate is just the rate at how much the carbohydrates or dextrose is delivered to the baby. And Dr. Abel, I know I had read somewhere that it's basically to prevent hypoglycemia in infants.
And both hypo and hyper. Hypo is pretty serious, right?
Yeah.
So Xavier, actually, I was going to ask you a quick question because you answered that so quickly, and I have a feeling that's because of learning about the parental nutrition and advanced nutrition. Actually, that's what I was going to ask you. Where do we really probably focus more GIR, parentally or enterally? And I already gave you the answer.
Yeah, I did.
Yeah.
Definitely
okay.
parental. Because in enteral, it's not really dextrose. It's not given at a rate, right? It's just like the carbohydrates.
Yeah. Well, the dextrose are the carbohydrates in the inner enteral
Like
vein.
in the IV.
Yes.
Got it.
So it's very, very important that we monitor that. And there's different, Aspen guidelines gives us different guidelines. So you as a student would want to take time to learn each of these different terminologies on your own. You're grad students.
We got this.
Yeah. That's great.
All right, this is our last one.
Last one. So take a look at the picture. It'll help out.
Okay.
So the answer to this, doing so would stimulate the secretion of GI hormones. It also improves glucose tolerance. It also stimulates motor activity as well as bile flow, and that could decrease the risk of cholestasis. So what do you think this abbreviation is?
Oh, dude. Motor activity gave it away for me.
Yeah.
I think we all learned that in MNC, like motor activity, enteral nutrition.
Yes, so minimal enteral nutrition.
Yeah, and very, very important to start with some amount, especially breast milk, to stimulate the gut and to move. Was that your experience, Kira? How old was she before they could actually give her that first drop?
I don't remember, but it was it's just like a trickle feed just to keep
Yeah.
everything moving and
And,
Yeah.
and
Yeah.
get secretions of enzymes going in the gut. Yeah,
I'm
very,
not sure, but I think it minimizes also the risk of neck.
it does.
Mhm.
That's right. Yes. And because neck is usually some kind of bacterial in the gut. So yes. Excellent.
Wow.
Great.
Awesome. Okay, and I think the last thing that we have here, which we all is to know the different types of levels of care. So really quick, we're going to review all 4 levels of care. So Xavier, you want to take it away with our level 1?
Well, the level 1 is going to be the newborn nursery. This is a kind of nursery that has a clinical team of healthcare providers who are going to be taking care of babies who are on term, basically those who are about 40 weeks on age.
Mhm.
Now, these 40-week-old babies, they happen to be that they can be breathing on their own and they can maintain their own personal body temperature. They have to be healthy. Now, in this exact same level, you're gonna have babies who are 35 and 37 weeks as well, but they have to be stable. They cannot have any conditions where they cannot be breathing by themselves and the temperature cannot be fluctuating. And then we also have babies who are gonna be sick and be born before 35 weeks, but they cannot be moved into a nursery with a higher care, only when they need higher care.
Got it.
Yeah, and that would bring us to level 2 NICU, which would be the special care nursery. The special care nursery is generally reserved for babies who are born at or after 32 weeks, who would weigh more than 1,500 grams. So that more than 1,500 grams, like we went over, would be low birth weight infants. Excuse me. So these babies might have some health problems, but they're not in very serious condition where they would need an extended period of higher level care. This nursery can also take infants born before 32 weeks or less than 1,500 grams, which would make them very low birth weight infants. But they would only be there for a short while before they are moved on to a higher level of care. So babies who need equipment to help them breathe would be here. These babies should stay in this nursery for about 24 hours or less. And if they need help breathing any longer, then they would be moved on to a higher level of care, which Janine, do you want to tell us about that one?
Yep. So that would bring us to our level 3, which is the neonatal intensive care unit, or our NICU. So the NICU is going to require an actual clinical team that's going to take care of babies that are born before 32 weeks who weigh less than 1,500 grams. So there can be babies of any age or weight also in the NICU, provided that they are also critically ill. So babies who, for example, need equipment to help them breathe, if they need to be intubated or like have respiratory issues, babies with different other conditions that we know they're going to experience these conditions before they're actually born. So we'll already know whether or not the babies are going to be admitted or have to stay in the NICU, just like in Micaela's case with Kira, where they knew that she was going to have to stay in the NICU. For how long was it, Kira? I think what you said, 87 days, right?
Mm-hmm.
This level 3 hospital NICU, sometimes babies have to be actually transported to a NICU, provided that that hospital doesn't have it. And once they start to get better, they can move down to the lower levels. The nursery has a full range of healthcare providers like pediatrics subspecialists, for example, like doctors who specialize in treating the children's heart, the lungs, or even the kidneys if should there be any problems. And also there's going to be specialized nurses who are specifically trained to work in the NICU and work with the equipment that's also in the NICU, such as, like you can see in the picture, those are the incubators to keep the baby warm and to try and mimic the actual gestational period as much as possible to be in the room. And because they're I believe the incubator is to keep them warm, correct?
to control their body temperatures. There's also sometimes a Billy light that could be either under the baby or above the baby if the baby's cholestasis is their jaundice. So, but yes, the incubator is about the body temperature because, as Kira mentioned earlier, some of these babies are literally born without their skin and they have no ability to control that body temperature.
So it's very serious.
Yeah.
And then we also have our last level, which Dr. Abel.
Yeah, so the level 4, often the NICUs will say they're both a level 3 and a level 4. Really the main difference is not only do they have all of the things that Janine just mentioned, the subspecialties, but they also can have even greater subspecialties where they could actually do certain surgeries that maybe a level 3 cannot do. They might have certain equipment. For example, in the picture on the right is something called extracorporeal membrane oxygenation. It's ECMO. And a lot of people don't know what that is, but that's where we actually bypass the baby's heart and their lungs. Now, ECMO won't actually heal the baby if there is a heart problem or a lung problem, but what it does is it gives rest to both the heart and the lung, and then it allows sometimes for healing to take place because of the rest. But can you imagine all of your breathing on a machine and all of your heart circulation, the blood going through is actually running through a machine to give both the heart and the lungs a rest. They're usually on that a machine for anywhere from 5 to 8 days, and they could actually even be on it longer, but it can be life-saving. They are required to have a neonatologist and 2 nurses at the bedside 24 hours a day. So it's very, very intense. The parents can, this is a father, can go in and see their baby. It's usually used as a last resort when both maybe the ventilator, the mechanical ventilator is not working, or other therapies and treatments are not working. But often on the picture on the left, they're actually doing a surgery right at the bedside. Kira, did you actually see any surgeries take place right in the room with your baby?
Not with my baby, but I saw other babies getting the PDA closed.
Yes, very common.
Mm-hmm.
Yes, yeah. So it's pretty intense. In many of the nurseries, there are not private rooms. What they have is anywhere from 6 to 10 babies in one unit. And so it can be a hard time because sometimes the moms and the dads interact and talk with the other parents. There's an element of compassion and concern. And then all of a sudden a baby might not be doing so well and could even pass it. And so there is a lot of intensity in the whole NICU. But this particular presentation, it is important that you start to understand all of these different terminologies and these disease states and just what goes on at these different levels of NICU, and then the different birth weights. Don't forget your assignment where you'll be doing calculations and you'll be choosing 2 of those disease states and providing more information to post in Canvas. Have a great day. Bye-bye.
Bye. Thanks, guys. Bye.